Welcome everyone. Today we talk about wound bed preparation. This is the key for good results with cold atmospheric plasma therapy. The title of this talk is Ready or Not. We will show why the wound bed decides the outcome. In part 1, we will learn how a wound bed should be prepared to get the most effective CAP therapy. We start with the basics of physics and the mechanism of action. Then we look at what plasma actually does to bacteria and skin cells. From there, we build the case for why preparation matters, using a practical ready or not example, and we translate this into a treatment regime depending on wound phases. In part 2, we will see how the same preparation principles apply in the peri-operative setting. We look at the indications and mechanism before surgery, walk through the pre- and post-operative protocol and back it up with case examples and evidence. Let's start with the physics. Matter has 4 states: solid, liquid, gaseous, and plasma. Plasma is the 4th state. Cold atmospheric plasma, or short form CAP, is a partially ionized gas. Its temperature stays low with a maximum of 40 degrees Celsius. CAP has a so-called dual effect. It works locally with high energy and it inactivates bacteria, virus and fungi, effectively and sustainably. At the same time, it stimulates the cell renewal. This slide shows the two-fold effect or dual effect of CAP. One effect works on bacteria, the other effects work on human cells. We explain both effects in detail on the next slide. So take a look on the effect on bacteria. CAP acts on prokaryotic cells, meaning it acts on bacteria. Reactive oxygen and nitrogen species, ROS and RONs, destroy intercellular structures and form micropores in the cell membrane. This inactivates microorganisms and viruses and gives CAP its bactericidal and virucidal properties. And again, CAP inactivates the bacteria, fungi and virus that we typically find in infected wounds. The mechanism is purely physical. It means it works independent of, for example, antibiotic resistance, and bacteria do not develop resistance against plasma. So let's back this with clinical examples and evidence. This is a plasma care trial from Japan, led by Dr. Terabe. The trial included 7 diabetic foot patients. After only 1 week of plasma treatment, we saw a clear reduction in bacteria. So let's move over to the second part of the two-fold effect. CAP also acts on eukaryotic cells, meaning on human cells. Here the reaction to ROS and RONs is different. The cells respond with survival mechanism against the oxidative stress. They produce, for example, inflammatory cytokinins or growth factors. They release antibacterial peptides and induce their own cell recovery machinery. The result is a positive influence on the cell biology, which stimulates human cell recovery. So this means plasma also acts on skin cells. It promotes cell metabolism and the angiogenesis. This is the formation of new blood vessels in the tissue. This gives the wound a better supply of oxygen and nutrition. This supports the healing. The latest research shows that plasma can normalize also the pH value. Overall, CAP has a positive effect on human cells and it hinders the growth of bacteria. So let's look at a case example for this. A young patient had a heel blister from a tight ski boot. We treated the wound with CAP. 3 treatments in total. At day 0, this was the initial presentation. At day 3, after only 2 cup treatments, we already see improvement. At day 6, after 3 cup treatments, the wound was healed. The result? A complete healing after 3 cup treatments over 6 days. Very impressive and very fast. Now let's look at the treatment frequency and goals based on the healing phases. In the inflammatory phase, we recommend to treat 2 to 3 times per week. The mechanism here is antimicrobial without resistance. It reduces inflammation, exudate, and pain. It improves wound bed pH and viability. It reduces fibrin and slough formation. In the proliferation phase, we recommend to treat 1 to 2 times per week. Here the mechanism is regenerative. It stimulates cell metabolism and cell division. It improves the collagen synthesis, the remodeling, and the alignment. It promotes microperfusion and granulation. In the epithelialization phase, we treat it once weekly or every second week. For acute or surgical wounds, before complications develop, we recommend to treat 1 to 3 times in total on day 0 to day 3. So this is the most important slide. Before treatment, clean the wound mechanically. This means debridement. Remove non-viable tissue, biofilm, and blood if necessary. This ensures direct interaction between the cold plasma and the wound. Cap is a charged gas. It will not penetrate necrotic tissue, slough, fibrin, callous, or other non-viable tissue and biofilm. After treatment, apply a standard wound dressing. And never use disinfectant before plasma. If necessary, use it after plasma. The next question we have to ask is the wound acute or chronic? For acute wounds, for example trauma, burn, or surgical wounds, we plan a minimum of 1 to 3 cup treatments. This is for day 0 to day 3 after the wounding event, if the wound is not yet stalled or infected. For chronic wounds, for example, diabetic foot ulcer, venous leg ulcer, pressure ulcer, ischemic or other stalled or complex wounds, we plan a minimum of 5 to 9 cap treatments. This applies if the wound is already potentially stalled or chronic. So let's summarize the treatment goals. For prophylaxis, the goal is infection control, biofilm control, and wound bed quality. This applies to acute, trauma, burn, or fresh surgical wounds. We reduce local infection and inflammation. We prevent the recurrence of biofilm and bioburden. We improve the pH and the protease balance. Another goal is pain reduction, tissue regeneration, and scar quality. We reduce and prevent pain. We support the collagen synthesis, granulation, and closure. And at least we improve the cosmetic appearance. But cap therapy alone is often not enough. We must also optimize the non-plasma factors. First, the perfusion, blood flow and oxygenation. Second, debridement, removal of non-viable tissue and biofilm. This can be surgical or sharp debridement, ultrasonic, mechanical, or biosurgical with maggots. Third, the moisture balance. Fourth, pressure offloading, for example in DFU or pressure ulcer, and the edema control in venous leg ulcer. Fifth, the nutrition. For all patients, check the albumin, pre-albumin, vitamins and minerals. For diabetic patients, control the blood glucose. 6 other systemic factors: cardiovascular, renal or oncological, and also autoimmune conditions. Also consider medication adjustment or compliance. Debridement is the key to success. Only once necrotic tissue, biofilm and debris are removed do we expose a viable wound bed, and only there can the cold plasma exert its reactive effects, unhindered. So this is something you have always to remember. Let's go one step deeper. Wound bed preparation is critical for CAP therapy. The plasma is a charged gas, and the charged gas must touch viable tissue. On the right side, we see wound bed that is not yet ready. For CAP, it shows heavy biofilm, fibrin or slough. It shows necrotic tissue or ischium. It shows rolled or curled wound edges or other non-viable tissue types. On the other side, we see wound bed that is really ready for CAP. It shows fresh bleeding, an acute infected wound with exposed viable tissue. It shows granulation. It shows epithelialization. It shows other viable tissue types. Let's summarize part 1. CAP works twofold, antimicrobial and regenerative. It is purely physical and it does not induce resistance. The charged gas only reaches viable tissue. Non-viable tissue and biofilm blocks its effect. Debridement is a precondition for CAP therapy, not an optional add-on. Treatment frequency follows the wound phases, from 2 to 3 times weekly in the inflammatory phase and once weekly in epithelialization. Non-plasma factors such as perfusion, pressure offloading and nutrition must be managed in parallel. Clinical evidence shows significant reduction in bacterial load and wound area reduction after only a few treatments. Ready or not, assessing the wound bed decides the outcome before every treatment. Now we move to part 2, CAP as wound bed preparation for surgery. Here we focus on vascular and plastic or reconstructive procedures. Why extended wound bed preparation before the operating room? A well-prepared wound bed gives the surgeon a better starting point. It supports the step from an open wound to a closed suture line. Let's look at the indication where the need for wound bed preparation before surgery is obviously. For vascular surgery, it is chronic ischemic or diabetic foot wounds before revascularization or debridement. Wound bed conditioning before skin grafting, after bypass or angioplasty. Amputation level wounds and infection control before closure. Support of stump healing after amputation. For plastic and reconstructive surgery, it is donor and recipient side preparation before skin grafting, wound bed conditioning before flap surgery, and open wound bed before autografting. CAP works with 3 mechanisms in the peri-operative setting. The first is the infection control. CAP is bactericidal and purely physical. It does not induce resistance. It reduces the bioburden before the incision. Second, the microperfusion and flap viability. CAP promotes angiogenesis. It gives a better local oxygen and nutrition supply. It supports flap and graft survival. Third is the collagen synthesis and margin quality. It stimulates cell recovery. It supports the suture line and graft margin. It improves scar quality. The main question is the wound bed ready for surgery? A ready wound bed shows granulation or viable epithelialization tissue, controlled exudate and no signs of infection, and an adequate perfusion. A wound bed that is not yet ready shows heavy biofilm, fibrin, slough, necrotic tissue, uncontrolled infection, or inadequate perfusion. The final assessment of operability remains a surgical decision. CAP supports this decision. It does not replace it. Let's look at the pre- and post-operative protocol. For unsuspicious wounds, we use the acute or surgical regime. This means 1 to 3 CAP treatments in total in the days before the procedure. Infected or critical wounds, we use the chronic regime with 2 to 3 treatments per week until the wound bed is ready. Post-op, we support the suture line, flaps, grafts and donor sites. The frequency follows the healing phases. The timing is always coordinated with the surgical schedule. It is not a standalone treatment pathway. But let's be clear about the limits. CAP does not replace surgical debridement, antisepsis, or the surgeon's operability assessment. When in doubt, treat the wound bed as not yet ready and reassess the wound. So let's summarize also part 2. Again, we have the two-fold mechanism, the antimicrobial and regenerative effect of cold atmospheric plasma. CAP is always an add-on option and never a stand-alone pathway. Debridement in wound care is mandatory. Effective preparation is also mandatory to save time and reduce complications. This is relevant for pre-op and post-op wound care. Assessment before treatment is essential. Evidence-backed results supporting the CAP therapy. Let's close today's session. 2 settings and 1 mechanism. CAP prepares the wound bed in chronic wound care and before surgery. Ready or not decides the outcome. In both settings, we must assess the wound bed conditions first. So thank you for listening, and now I'm happy to take your questions.